السلام عليكم. Our case is case discussion. يعني هي one case عايزين interactive من الناس بس معانا في الحالة ان دي المين. طبعا انا يعني الدكتور اسامه بيه قال ان ما ينفعش اخش بعد دكتور عصام بيه ودكتور اسامه، فانا مش عارف الصراحه. المفروض انا انزل زي ما قلت لحضرتك كده، انا انزل بالظبط كده. فلوتنج بس انا عشان
خلي بالك من الوقت يا دكتور علي.
لا حاضر بيه، هو الوقت قليل جدا. ما هي الحاله بس one question وهنكمل الحلقه على طول. بسم الله الرحمن الرحيم.
الدكتور علي فرجاني is one of our consultants in the trauma unit and in pelvic and acetabular fracture team.
Our case is female patient, 19 years old with combined pelvic and acetabular fracture at the right side with ipsilateral fracture femur as we see in the X-ray. My question, what to do? Start by diagnosis. What is the diagnosis of this case? What is the classification of this case? دكتور عمر ياسر موجود؟ عمر ياسر مش موجود؟ لو الدكتور ياسر موجود هو يجاوب. عمر ياسر موجود. What's the diagnosis دكتور عمر؟ بسرعة عشان الوقت. أيوة دكتور عمر.
This is a fracture pelvis and acetabulum with ipsilateral femur. It's a floating hip.
Floating hip, yes. How can classify this according to Muller classification?
Type A, type C, type C.
C or A?
C.
A with acetabulum, B with pelvis, C both pelvis and acetabulum. So it is, yes, as you diagnose the case, you will see the fracture site at the sacrum, at the site. The sacrum is broken, and the acetabular fracture. As we see that there is medialization of the head, and the roof is separate from the axial skeleton. So, as acetabular fracture classification regarding to laterality is associated with column fractures. How to treat? Start by pelvis or by femur? Who agree with pelvis, acetabulum and pelvis first? Femur first? Yes. All of us start by femur first, then we go to fix the acetabulum. We use the modified stoppa and the iliofemoral to reach the lateral part of the roof of the acetabulum. And this X-ray post-operative, and this is the wound of our patient. And follow up after 8 weeks, and follow up after 6 months. As we see, the fractured femur is uniting, and the pelvis and the acetabulum is still continuous. 1.5 years, just the screw of the iliosacral screw just be loose. Because I think if it's fully threaded will be the best, or reaching the iliac bone as the other side more rigid. And this X-ray and the femur united as the clinical view of our patient. Case number 2 is more difficult. What's your opinion now? How to do? I need anyone to classify the acetabular fracture. Oh. The iliac and obturator views and the CT. As the CT, we have a specific sign in this patient. This patient have mainly anterior column fractures with medial displacement in the quadrilateral, but there is impaction in the posterior. You see this part, I enlarge it, this impaction in the posterior part. The aim of this patient is, we know well, high risk for AVN, and later on he need total hip replacement. So we will do the most simple one. we have to reduce the acetabulum and fix the trochanter and follow up the patient. This patient, he had short follow-up, just 1.5 months, but it's more difficult. So I need anyone to say to me how to treat, which approach. You start, Dr. Omar, start from anterior to the acetabulum. Anyone else? We will start with femur first. يا جماعة عايزين حد طبعا، ما حدش مش انتوا مش هتعملوا خالص العيان؟ Yes, of course. In this case, there is something wrong intraoperative. The acetabulum of the anterior is reduced. The head like bucket handle. It is inside and the column reduced. If you open just modified stopper or ilioinguinal, you cannot remove. We do first. We open modified stopper and try to reduce the hip. It is more difficult. So we open both approach at the same time. You see in the 3D, the posterior column looks like no fracture. Merely anterior with fracture. We open both at the same time. We open lateral, just this small approach first, so do reduction. Later on, extend our approach to fix the femur. Intraoperative, we use the laminar spreader to open the anterior column to reduce the head. We open the anterior column fracture by laminar spreader first, and then push the head outside and fix like this. This X-ray postoperative and CT postoperative. As we see, even the posterior impaction, some reduced. We can't do anything to this. It is more difficult. And these 6 weeks follow-up of our patient, and the patient is partially with bearing now. Our take-home message, the floating hip is more difficult, not the same case done by the same approach. I thank my all colleagues and my team in the pelvic and acetabulum and the surgeon who helped me in this case, and thank you.